A brief discussion about kidneys endocrine function. So the erythropoietin that is released by interstitial cells in peritubular capillary beds in response to hypoxia. So when there is hypoxia, that will lead to release of erythropoietin. So this will stimulate RBC proliferation in bone marrow. So the erythropoietin often supplemented in chronic kidney disease. So when the kidneys are chronically damaged, so the erythropoietin cannot be produced. So the erythropoietin can be supplied by any external source. This erythropoietin is produced in liver in fetus. Another is calciferol or vitamin D. This is the proximal convoluted tubule cells convert 25 hydroxide vitamin D3 to 125 dihydroxy vitamin D3 calcitriol, that is an active form. So this active form will absorb calcium and phosphorus from our gastrointestinal tract. So as you can see, 25 hydroxy D3 will be converted to 125 dihydroxy D3 with the help of 1 alpha hydroxylase. So there will be the stimulation by parathyroid hormone. Prostaglandin is also released by kidney endocrine. So para-acinar secretion vasodilates the afferent arterioles to increase renal blood flow. So this prostaglandin helps in the increased renal blood flow to the kidney, or as you can say, these are the safeguard of our kidney. So the NSAIDs or non-steroidal anti-inflammatory drugs block renal protective prostaglandin synthesis. NSAIDs will block the renal prostaglandin synthesis, so that will result in constriction of afferent arteriole, and that will lead to decreased GFR. So this may result in acute renal failure in low renal blood flow states. I hope you can understand. Another hormone produced by the kidney is a dopamine. So this is secreted by proximal convoluted tubule cells, promotes natriuresis. At low doses, this dopamine dilates interlobular arteries, afferent arterioles, and efferent arterioles, that will result in increased renal blood flow. So there will be a little or no change in GFR, while at higher doses this will act as vasoconstrictor. So this shows that dopamine has two functions. At low doses it will increase renal blood flow, and at higher doses it acts as a vasoconstrictor. So our discussion will be about hormones acting on kidney. Atrial natriuretic peptides that are secreted by our heart atrium. So this is secreted in response to increased atrial pressure. This will cause increased GFR and increased sodium filtration with no compensatory sodium reabsorption in distal nephrons. So the net effect of this atrial natriuretic peptide will result in sodium loss and volume loss. So as we already discussed about angiotensin 2, this will synthesized in response to decreased blood pressure or blood volume, causes afferent arterioles constriction, that will result in increased GFR and increased filtration fraction, but with compensatory sodium reabsorption in proximal and distal nephron. So there will be a net effect of preservation of renal function in low volume state with simultaneous sodium reabsorption. So both proximal and distal convoluted tubules to maintain circulating volume. Another hormone is a parathyroid hormone that is secreted in response to decreased plasma calcium, increased plasma phosphorus, or decreased plasma 1,25 dihydroxy D3, or you can say active vitamin D. So this will cause increased sodium absorption in distal convoluted tubule and decreased phosphorus reabsorption in proximal convoluted tubule and increased 1,25 dihydroxy D3 production. The calcium and phosphorus absorption from gut via D3 always occurs. So this vitamin D3 has a function to absorb calcium and phosphorus from gut. Aldosterone secreted in response to decreased blood volume and increased plasma potassium. So this will cause increased sodium reabsorption, increased potassium secretion, and increased hydrogen secretion. So the ADH vasopressin is secreted in response to increased plasma osmolarity and decreased blood volume. So this will bind to receptor on principal cells, causing increased number of aquaporins and increased water reabsorption. So the mechanism of that we already discussed in our previous videos. So another topic is about potassium. So when the potassium is shifted into the cell, that will cause hypokalemia when the potassium moves into the cell. The causes of hypokalemia include hyposmolarity, alkalosis, beta-adrenergic agonists that will act on sodium potassium ATPase and they will increase their activity, and insulin also increase sodium potassium ATPase activity. So insulin shifts potassium into cells. Insulin shifts potassium into cells. So if the potassium comes out of the cell, that will result in hyperkalemia. The causes of hyperkalemia include DULABs, so digitalis, which blocks sodium potassium ATPase activity, hyperosmolarity, lysis of cells as in crush injury, rhabdomyolysis, tumor lysis syndrome, acidosis, and beta blockers. The beta 2 blockers are the most important in causing hyperkalemia, high blood sugar, in insulin and insulin deficiency, and succinylcholine, increased risk in burns and muscle trauma. When in diabetic acidosis, there is loss of intracellular free water that will result in extracellular movement of potassium secondary to increased intracellular potassium concentration. So let's talk about electrolyte disturbances. When the sodium is low in concentration, low serum concentration, that will result in nausea and malaise, stupor, coma, and seizures. When the sodium is high in serum, so the concentration is high, that will lead to irritability, stupor, and coma. When the potassium is low in serum, so that will lead to hypokalemia. Hypokalemia causes U waves and flattened T waves on ECG, arrhythmias, muscle cramps, spasm, and weakness. When there is high serum concentration of potassium, that will lead to wide QRS and peaked T waves on ECG, arrhythmias, and muscle weakness. Okay, let's draw a simple ECG. Alright, so here we have a ECG when there is decreased concentration of potassium in the serum, so that will result in formation of the U wave and flattening of the T wave. There is a mnemonic: U have no pod and T but long PR. So from pod we have P, from T we have T and but long PR. The mnemonic is you have no pod and T but long PR. So when the concentration is less than 3.5 to 3, so there will be a U wave on the ECG. When the concentration is in between 3 and 2.5, so there will be changes in P wave. When the concentration of potassium in the serum will be in between 2.5 and 2, so that will lead to flattening of the T wave. As you can see, the T wave will be flattened. So when the concentration of potassium in the serum is less than 2, so that will lead to the interval between P and R will be increased. So there will be a long PR interval. So let's suppose here is a P wave, long PR interval, and flattened T wave, or you can say another U wave. So when the concentration is less than 2, so that PR interval will be increased. Hypokalemia can lead to formation of U waves and flattened T waves, while PR interval changes and P wave changes on ECG. Okay, so let's talk a few words about hyperkalemia, the ECG changes of hyperkalemia. Let's suppose here we have a normal ECG. So when the concentration of potassium is increased in the serum, as the concentration is 5.5 to 6, so what will happen? The ECG will be like that. Let me draw. Yes, so as you can see, the T wave will be 1/2 of the QRS segment. So let's suppose here we have, so the T wave will be 1/2. So when the concentration of potassium is 7, so there will be change in P wave and the flattening of QRS segment, and there will be a raised, or you can say peaked T wave. So when the concentration is high, there will be a sine wave like that. The ECG pattern will be a T wave will be larger and the P wave, QRS segment, T wave. So it's like a, so as you can see, this is going down, this part is going up. So this is the pattern in hyperkalemia. This part start going up and this part start going down. So here you can see, here is a sine wave that it is present in when the concentration of potassium increased more than 7. So that pattern will be present. Okay, now we will move to calcium. When there is low serum calcium concentration, that will lead to tetany, seizures, prolonged QT, and twitching, that is known as Chvestic sign. So to check this sign, you will put pressure on a patient's face just 2 centimeter forward to our auditory canal or auditory matters. So while you will press the finger, after that there will be automatic twitching of the face and spasm, that is known as Trosso sign. So when you place a BP cuff on a patient's arm and inflate it and remain it inflated for 3 minutes, so after that the patient's fingers will be flexed inward, and that will known as Trosso sign. So while there is increased serum concentration of calcium, that will lead to renal stones, bones will be painful and abdominal pain, and there will be urinary frequency increased, and there will psychiatric overtones, that is anxiety and altered mental status. So for hypercalcemia, there is anemonic stones, bones, groans, thrones, and psychiatric overtones. So magnesium, when there is decreased serum concentration of magnesium, there will be tetany, torsades de pointes, hypokalemia, hypocalcemia, when magnesium is less than 1.2 milligram per deciliter. So in increased amount of magnesium or hypermagnesemia, there will decrease DTRs, lethargy, bradycardia, hypotension, cardiac arrest, and hypocalcemia. So when there is low serum concentration of phosphorus, that will lead to bone loss, osteomalacia in adults, and rickets in children. So while there is high serum concentration, that will lead to renal stones, metastatic calcifications, and hypocalcemia. So phosphate binders are calcium acetate and sevelamer, that will lower serum phosphate in patients with end-stage renal disease. These two drugs are very important. Calcium acetate and sevelamer is a non-absorbable phosphate binding polymer that decreases absorption of phosphate in GI tract, that results in, and this drug is used in treatment of hyperphosphatemia in dialysis patients.